Everybody to this Monday edition of the Coding and Compliance Roundtable. Um, I'm glad that I clicked the go live button because Paul Spencer was about to serve me up a dish of something that I probably don't want to have today, but it's all good other than that. As always, I want to welcome our distinguished panel, our subject matter experts, Stephanie Allard, Scott Kraft, Terry Fletcher, Paul Spencer. It's great to have you all with us. Today, I'm kind of trying something a little bit different with us all being in equal boxes. So we're not having to kind of fling around on who's talking, and we all are about proportionately the same size. So, with that said, welcome to each and every single one of you who is tuning in, logging on, and just hanging out with us for a little while as we get an opportunity to talk about all things coding and compliance. Today we have some really great topics, and we added a couple of last minute conversational topics. And I think I actually want to start there, Scott and Paul, if you don't mind. Um, we're seeing more and more comments coming in regarding evaluation and management services, um, providers uh, documenting time on every single encounter, but not utilizing time. And some of the other faux pas, like I get to bill a level 4 because my moderate level of risk, because I wrote a prescription, somebody told me I can bill a 4. So I want to deal with some of those fallacies and I want to deal with some of the misperceptions. And then we have a great lineup today. We're going to be talking about some of the crazy things going on with the Health Insurance Portability and Accountability Act. And then we're going to transition into remote therapeutic monitoring, remote patient monitoring, and having a discussion about chronic care management and how that differs. And I know we'll be relying on our good friend Terry to help us guide through the telehealth aspect of some of these things because they are RPM and telehealth are not the same thing. There are inherent differences between them. So, with that said, good morning to everybody on the panel. Good morning to everybody out there on the intraweb. And with that said, Scott and Paul, let's talk about what y'all are seeing in some of the recent audits that you all are working on, and let's try to bring people back from a level of insanity to sanity.
So I'll start, and I know we've talked about a couple of these things in the past, but the way I want to say it to begin with is no matter what set of documentation guidelines we use today or will use in the future or have used in the past, I think there are two important things to remember. One is that medical necessity of what you're doing or what the provider is doing sits behind all of these things. What is necessary is what should be done and what should be built. And there is no set of documentation guidelines that I've seen or probably will see that cannot be, and I'm not accusing anybody of doing anything untoward, but at the end of the day, it's a set of guidelines where you're told if you document things in a certain way, it achieves a certain level. But still, we must remember medical necessity. So there's no set of guidelines that you can't essentially document to get to a certain place. So one of the things about the 2021 guidelines that came up in a question I had last week actually is this concept of time versus medical decision making. And there's no longer a counseling and coordination of care requirement related to time. It's really just how long did it take the provider on the date of the service and how was that time spent? And so I'm working with some physicians who are putting time in every single encounter that they're documenting. And look, this is often a template statement. The times magically always are 0 minutes or 5 minutes, or they have something like that. So when it comes to time, one of the things that we have to be thoughtful about is I can't read minds, right? And so I will have a provider tell me, well, I didn't intend to code this visit based on time, but I just put it in every note. And so that becomes problematic for me as an auditor in some ways because I'm trying to look at the documentation and I don't understand necessarily what the provider's intent was or how they've shaded time. And the reality is, it is time or it is MDM. Like that's the rule. So when I look at it, I'm trying to say, I'm applying the rule. What is the time? And so my recommendation, as it always is is that time be documented when it's the provider's intent to use it as part of coding. Because medical decision making, when you think about it, is not an either or in that way. You don't have a service without making medical decisions of some kind. So you can't just sort of splice that in and out like as needed. But I think it does add certainly a layer of confusion to things. And, one of the questions that I'd gotten was, well, do I just discard time when time is higher than medical decision making? No, right? Like in some ways, that's the utility of time because it covers these circumstances. And so, just to summarize before I turn it over to Paul, my recommendation when I talk to providers is use time in your note when you intend to use time as the reason you're selecting a code, and justify that within your time statements and throughout the note to establish the medical necessity of why you spent that amount of time.
So Paul, um, go ahead and comment on that, and then I want to kind of talk about the medical decision making aspect. So go ahead and finish.
Okay.
Go ahead and finish what your thoughts were, and then let's kind of move into that conversation.
Well, two things. First, Scott said something interesting about medical necessity sitting behind all of this. I would argue that it sits on top of it, as if you are climbing K2 and getting to a summit, and that summit is medical necessity. That's going to be the goal. We've talked before on this podcast about the things we left behind. Almost accidentally when we talk about E&M services and what changed in 2021 and 2023 respectively, depending on site of service. And it used to be in the old days that back in my day 2 years ago, that when you did an E&M service and you had to bill by time, you had to state that at least half of it was spent counseling, coordinating care, which is no longer the standard. But the more important thing, and the one thing you probably want to remember when you want to consider time versus medical decision making, is there needs to be some type of a narrative as to how you spent that time. And I know that with the laundry list of things that the AMA has put out, it's become far too easy to say, I spent 5 minutes doing this, and I spent 7 minutes doing that, and I spent 9 minutes putting it into the EMR. Well, that's kind of good as far as detail goes. But when you've got a situation where you have more time than you have a medical necessity level of service, it really helps to put a narrative in as to how you spent that time, other than a laundry list that's checking a box that says, well, these are the activities that count, and this is what I did in order to satisfy those activities on a minute by minute basis. Describe it. We always said tell a story. It still holds. 28 years after the 95 guidelines and in the third year now of the post 95, 97 guidelines, it's still about painting a clinical tale of the services you provided to that patient.
And I think that's a good point. And I would add to that, particularly as we see a lot of template statements with respect to time, that the note should really be reinforcing the template, right? Like, so if you're going to say I spent 30 minutes doing certain activities, we should feel a flavor for that in the history, in the exam as it's documented, and within the medical decision making. Because, like we said before, you don't really have a note without medical decision making, even when time is the factor that you're using.
What
You know,
about when you have a note that says it's based on time, and at the very last part of the note it says, and the scribe's name, and that they put it in the system, and the doctor used, I did the history, the exam, and the charting, and you also found out that the ancillary staff did the history. That's my favorite. If you read the rules, it says you can't use your staff. It has to be what the provider that's billing is doing. And if you use a scribe, you didn't chart it. Your scribe did. So, I'll actually take off time for that. And they're like, well, you can't take off that much time. Like, oh yes, I can, because now it's not even a compliant note. Or we can go by medical decision making. That's a level 2. Which would you prefer?
Well,
So,
and I typically say when you're documenting time and you're putting it into a template, going on to your point about the time that the provider actually spent, these should be activities that the provider actually did for that patient. And this is maybe my pet peeve, but even when a template says something like discuss the plan of care with patient/family/caregiver, etc., it's like it was, which of those it was, right? So you don't need to say it was all of them. And when you say you spent time ordering labs, I'm going to expect to see labs.
This is all
So
reminding me of a conversation I had this last week with a group of pediatricians. And after we go through everything, we talk about the guidelines, I explained it all in detail. I get asked, well, can you just give us the list of conditions that are level 4s then? It's like, oh man, were you not listening?
How do I get this
No,
to
I
a level
cannot
4?
give you a list.
What will
How do
make
I
it a
get how do
level
I get
5?
this to a level
Exactly.
4? How do I make
Yeah.
this a
Yeah.
5?
Well, what will
You know,
make
and
it a
one of
5? Yeah. No.
and one of the things I'll say about the importance of medical necessity, and I certainly see this in the work that we do as it relates to medical decision making, is a patient will present with a relatively modest problem, and the provider will order copious amounts of things. Sore throat followed by the order of 5 different labs and a antibiotic to potentially cover something, or an antibiotic because patient complained about it. So we still do always have to contemplate what the medical necessity of what the provider is doing is. And there's an interesting
so
comment in here I just want to call out before I hand it back to you, Sean. Just because it
yeah.
took an hour to take out a person's splinter, the medical necessity was to only support a lower level of service. And we see that stuff sometimes. I see it quite a bit where I'm kind of scratching my head, and I'm always reluctant to say something like this, but I almost want to say to the provider, can we act out? I won't charge you as your consultant, but can we act out that 40 minutes? Can we see like how you actually spent like that time?
So do people actually go to the doctor to have a splinter removed?
I wouldn't,
Yeah,
but
apparently in
The
Christine's part of the world they do.
Okay.
the last one I had on my fingering hand for guitar, my wife did it with a pair of tweezers and a really good nightlight. So that's my lesson for the day.
There you go, MacGyver. Okay, so we've spent time talking about time and, when it counts, when it doesn't count, how it should be documented, who should be documented, who should be documenting it, who shouldn't be documenting it. But I want to transition over to talking about medical decision making. And I feel like no matter how much we talk about evaluation and management services, and now they've been in place since 2021, these new guidelines, um, I, you know, I revert back to saying, well, look, we we were still talking about 95 and 97 guidelines all the way up until 2021 when the new guidelines took over. So, the potential for us talking about these things for the next 2 decades is possible. So, I want to transition over to talking about medical decision making, right? Because medical decision making, um, really to me, more than time, should drive the visit because medical decision making ties directly into medical necessity. At least it does for me in the way that I prepare for a hearing, in the way that I prepare for a trial. I look at those two not as synonymous, but I look at medical necessity as, again, the driving factor for why the patient is here and the decision making aspect, which is the plan of care that ties back to the reason why the patient came in. So, medical necessity drives medical decision making. Now, for whatever reason, folks are still, I shouldn't say folks, some providers are still of the mindset that if they write a prescription for a patient or they have prescription drug management, that that will drive the overall level of MDM to get them to a level 4, as long as one of the two other key components are met. Help. That's all I'm going to say. Help. Somebody please help.
No,
So,
everybody, no one
go
wants to
ahead.
take it. Yeah. I think what's really tough for me is the fact they went to 2 out of 3 components for both the new and the established. Because remember, it was only 2 out of 3 for established before, which made sense. But 2 out of 3 for new to me doesn't make sense. So when I saw that, I was like, okay. So and the other thing is that there's so much. I hate to use the word ambiguity, but if I've had doctors now that are reading the verbiage in CPT and saying, oh, it says if I did a history and or exam, so I mean I don't have to do one or the other, so I don't have to technically do an exam. And I said, what'd the patient come in for? And they're like, chest pain. I'm like, oh, you're not gonna I'm sorry, I don't mean to laugh, but you're not going to do an exam for chest pain. Or somebody said they came in for a mass in their inner groin. You're not going to see if it's there. So it's interesting to me when I get those questions, because medical decision making has three elements to it, and that's one of the 2 out of 3. So remember that there's 3 elements of medical decision making: problems and complexity of those problems addressed, not just listed. When we're talking about the data points and the collection of data and we're ordering and reviewing tests, it says and reviewed. How does it tie into what you're doing today? And then when we look at the overall risk of complexity on the patient, the assessment and plan, and the morbidity and mortality of the patient, how is what you're planning to do going to affect the risk on this patient today? Not the general risk of a procedure, the general risk of surgery. How does that risk tie to this patient? To give me your thought process, because there's patients that are going in for gallbladder surgery that are perfectly healthy, get out, maybe come in for one post-op and they're good to go. But if you've got a patient who maybe is 70 years old, is on Coumadin, has all kinds of different risk factors that could contribute to their morbidity and mortality, and the risk for that particular patient's a problem, it has to be documented so that we can get to those levels of service. And that's where I feel it's not
tight.
there.
Hang tight for just a second, because this is another one that absolutely drives me bonkers, right? And Haley, I'm so glad you put this up here, because the fact is, just because you are a specialist or a super subspecialized specialist and you have patients with terminal illnesses doesn't make every single patient visit a high complexity. Listen, unfortunately, oncologists are dealing with horrific, situations for patients that are terminal. They have, various types of cancer that are, depleting the person of their, abilities, their freedoms, their, health, whatever you want to call it. But if you have a terminally ill patient, even though they're on chemotherapy, who is stable with no changes to the current plan of care, and they present saying, I'm doing okay today, that is not a high complexity of medical decision making.
Try telling that to the oncologist who says it is. Yeah.
Well, and what I would add to that, I
Yes.
recently had a conversation about the way the guidelines are worded, and the basically the question that came up was some variant of when it says in the near term without treatment, or in the near term, like what does in the near term like mean? And one of the things I had said was it somewhat is reflective of the examples that are listed, right? When you see the examples, it's like an MI, it's like a stroke, right? And I because I had said, technically without treatment, like strep throat could kill you in 6 months, but that's not really what we would be like contemplating, right? And one of the things that I like about these guidelines, and I find myself saying this as a preface to good documentation, which I don't always see, is that these guidelines took us away from me having to penalize the provider for not doing what everybody involved knew was kind of like unnecessary busy work, right? Like you don't have to, as an ENT, perform like a musculoskeletal exam necessarily. You don't have to feel like you're doing these things because I'm going to come in and say, well, you didn't tell me the social history of this 98-year-old person. But what they do ask of you is that you write a descriptive note, as Paul had said, when you feel the note tells the story of the patient, then the risks to the patient become more evident when we think about things like category 3. So the question that it's when we talk about, as one of the questioners or commenters said, my favorite one is that everyone with blank is a level 4 or 5. The answer, of course, as we all know, is no, but it's really up to the provider to define the risk and document it in a way that enables us to credit them in alignment with the guidelines. And when they don't do that, it's not for me to assume it, it's not for somebody else to.
I kind of
Go ahead.
laugh at that one comment that said everything blank is a level 5. From an auditing perspective, that's the worst episode of Match Game I've ever heard.
Yeah,
But
seriously.
um, you know, I kind of I hate to always refer to song lyrics, but behind me is a British gentleman by the name of Robin Hitchcock, and he has a song that features the lyric, "God finds you naked and he leaves you dying. What happens in between is up to you." It's up to the doctor to define when, and whether whether that patient is close on that particular date of service. If they're not, it's not a level 5. you know,
Yeah, I just look here's what I would say, and then we'll move on to our next segment. The for me, I think the most important thing that anyone can do who is having concerns or questions regarding the billing of the levels of service, you've got to have an internal auditing process. You have got to be taking a look at these things and going back and pulling out the authoritative guidance from the Centers for Medicare and Medicaid Services. Sit down with your providers and go through it. The worst thing that you can do is keep it to yourself and continue to allow the problem to become systemic to the point where you receive an additional documentation request, right? An ADR or worse, notification of an investigation and audit by a UPIC, which again, they are seeking out fraud, waste, or abuse. And all of a sudden, something that could have been easily dealt with from a educational standpoint, a voluntary refund standpoint, to offset, for example, if you build a level 4 and it should have been a level 3 or a 3 and it was a 2 or a 5 and it was a 3. Remember, when an insurance company audits you and they find fault with what you have coded, they're not going to say, you build a 4, we should have paid a 3, so we're only going to ask for the difference between those back. They're going to say, you submitted a claim with the incorrect CPT code, thus, we want our money back because you were overpaid for a service. When you self-report, when you do a voluntary self-refund, the control is all yours. And I will tell you, in 25 years of doing this work, right, out of 30 years in this industry, whenever we make a voluntary refund or disclosure to an insurance company, we always go at them to say, all of the services that were performed were done so in accordance with generally accepted standards of medical practice. The services are medically appropriate, necessary, and reasonable. However, there was a misunderstanding on the part of one of our providers for whom we have implemented a corrective action plan, and thus we have done a proper look back period to where we believe the problem began, and we have determined that these services that we are making restitution on are the only ones that concern, and we are reimbursing you the difference between what we were paid versus what we would have been paid had the correct CPT code been filed. And that way, you're only giving back the differential. Be smart about this stuff. But the most important thing you can do, you got to have a policy in place. You have to have policies and procedures in your compliance plan that specifically lay out the steps that are taken to conduct these investigations. You can't simply say, we've always done it this way. It doesn't work. All right, Scott, what do you have to add?
Yeah, there was one comment that came in. My patient population is blank, which makes them a 99215. And I'm reminded of a provider that I worked with a few years ago who I won't say the specialty, but basically the case he made to me that he was one of the preeminent providers in that specialty, as such that he had started like a special center for the management of conditions within the health system that were targeted toward that specialty. And consequently, anytime he would see a patient, it would be a level 5. And someday I'm going to write a book of things I think about, I want to say, but I know it's probably good for my health in that moment to like not say. And the thing that popped into my mind was like, if you built the most like opulent car repair shop in the world and I came in for an oil change, I still only want to spend like $30. And so it really all depends upon what the specifics of the patient's case is, not, the overall, this condition in the aggregate is always this, or this, where I choose to seek care is always this. I mean, the patient is what the patient is. And like I said before, I think the documentation guidelines, what I like the most is it licenses you as the provider to focus on describing them and treating them in that way and not getting involved in all these other things.
All right. Excellent, excellent segment. All right, Terry, I want to move into HIPAA. And once again, thank you for catching my typo this morning. Because once again, it's a Monday, and I went with the double P versus the double A, and stop shaking your head, Paul. It's a Monday. All right.
Paul's like, oh,
So,
Sean. All right,
so
so let's head right in there.
Terry, what's going on?
First, I wanted to comment to the people watching. I'm in Arizona at my daughter's house, and people keep commenting about the knives behind me. So I'm laughing because I just got like 4 texts on that. Yeah, I'm in her kitchen, in her dining room. So just so you know, it's not planted. That's not how we feel today about you. It's just there. So kind of ignore that. I'll move this way. But I just thought it was funny how you guys pay attention to our backgrounds. I'm not in my office today. So talking about HIPAA, I've had some really interesting questions. And these questions haven't come up since the very beginning of COVID. Remember when all the, professional athletes and the politicians who don't know anything about anything, they basically say, "Oh, you can't ask me if I'm, COVID vaccinated or if I've had it or anything. That's a HIPAA violation." No, it isn't. If a reporter's asking it, no, it isn't. They're not a HIPAA entity. Remember, HIPAA entity. But here's some questions, and I'll put out to the panel because maybe you can help answer these for me. I thought some of them were kind of like, I don't know. So a practice said, we sent a patient claim to the wrong payer. Well, I'm thinking at first, yes, because there's diagnosis information, there's patient protected information on there, and it went electronically. So to the wrong person, I would think that would be a violation. But I'll see what you guys are doing. There was another one that says a coder's having lunch with a friend at a restaurant and they're sharing patient health information with someone. And then that person overhears and tells the patient who they know. So they're having lunch with someone from their office at, the local restaurant. And then somebody at their next table overhears this and then tells the patient. So that's a violation for the office, but not the violation for the patron who heard it, because again, they're not a HIPAA entity. But the office can get into a lot of trouble. Everybody agree with that? I think I'm talking about it.
Let me go back to the first one real quick, Terry.
Yeah.
So I know that there's some folks that would actually think out of the gate, well, wait a minute, Sean, why is it a violation if it's covered under treatment, payment, and operations, right? Under the payment aspect of TPO. It's because it was sent to a payer that is not covering that life.
Patient,
They
right.
don't have the right to have access to that protected health information. Folks, and let me just say this before Terry goes on with some more examples. The Office for Civil Rights has for several years gotten very aggressive. The number of HIPAA resolution agreements that are going out on a monthly basis, phenomenal. And even if you believe that doing a disclosure on what's called a reportable event is going to keep you out of the crosshairs of OCR, it's not.
Right.
It may help to lower your negotiated settlement amount and to possibly reduce you from a 3-year resolution agreement down to 2 years or 2 years down to 1, but you will still have fines that are levied against you. You will still have to enter into a resolution agreement and you will still have to be monitored. Okay, go ahead, Terry, with some more examples.
And the next one I wanted to bring up, because all of us, I think, on the panel, we're going to be participating in the NAMAS virtual conference coming up April 5th and 6th. So I wanted to put that out there because we're going to be talking about a lot of these topics as well from a webinar and educational standpoint, not just a conversation. But one thing that's going to be coming up is that if you use a non-HIPAA compliant telehealth platform past May 11th, you're not going to be HIPAA compliant. Stephanie brought this up at one of our last roundtables, where she said HIPAA didn't go away. Remember, HIPAA didn't go away. The Office of Civil Rights and the HIPAA police, I like to call them, they basically said as long as you're acting in good faith during the public health emergency, you're not going to get a violation, report, and you're not going to get in trouble as long as, again, in good faith. But it's up to them what they think is acting in good faith. But the biggest thing that you have to keep in mind here is the fact that May 11th is right around the corner. So that's one thing. So here's one, a practice. I don't know how many times you guys have this. Pretty funny to me. Funny in a way that's not hilarious, just funny because I can't believe they're doing that. So somebody will send me records, unredacted, and say, hey, what's your charge for reviewing these? Can you audit these? Scott's laughing because I know he's got it. I don't know, Paul or Stephanie, if you guys ever had that, but I get a whole thing of PDF records. The last one I got was over 300 records from somebody and said, hey, just let me know how much this will cost. Can you do it? Never said, hey, Terry, how you doing? I'm from this office. Can you do this? I found out because it was in their signature line, but it's a good thing I didn't open it because I'm just like, did you redact, or do we have a BAA, or do we have anything there? And they said, oh, we have to get that. But I've heard you on the podcast. Oh my gosh. And then did you also stay at a Holiday Inn Express? It's interesting to me because I think that you have to know what is HIPAA protection means the patient's private health information cannot be shared without their permission or without an agreement from healthcare entity to healthcare entity. You have to understand that. So fulfilling a request, this is one I think I just want to make clear. Fulfilling a request from another medical practice for a patient records without the patient's consent is actually what I meant to say. If the other entity treats the patient and they're asking for records for the other patient, that doesn't require patient consent. It's basically under a different HIPAA policy, and I can't think of it off the top of my head. But that's okay. That's like HIPAA to HIPAA. You can do that. Scott, you know what that is, right?
Yeah, I had an interesting thing about that when I think about the care we should take with our patients' records. It was a situation very similar to what you described, except the entity that was requesting the records was using a vendor to facilitate that they had their own agreement with, right? And so in my mind, at least, these are things you verify, because all they really could see in this request was the logo of the entity and a couple of names, and that was the question I got, right? It was like, well, this they claim they've treated the patient, and can we share the records? And my response was, look, this is an entity they've contracted with. There's essentially a third party in here. I would call them, right? Like, pick up the phone and call the lady's name who's on the thing, just to make sure, because we all know how many things out there are being, faked and all the rest of it.
So one thing I do want to say, um, when you have a violation of HIPAA, it is a reportable event. Okay. Sitting on it, not making a disclosure, not doing anything about it, more problematic for you should somebody else figure out what your problem was. Recently, I had a client not long ago. They created their own HIPAA violation. And let me just tell you this. Telling your chief compliance officer or your privacy officer that the mistake happened because it was 5:00 and you were rushing to get home because you had another appointment isn't an excuse. If you send an email containing protected health information for one patient to another patient by mistake, you have a breach. You have a reportable event. It has to be disclosed. Now, it could be a first tier violation, but you're going to have to show corrective action to ensure that it doesn't happen again. And I will tell you some lessons learned. Make sure that if you report a breach or a violation to the OCR, they're going to want to look at everything. It's not just narrowed to that scenario, because their investigators will start asking questions. Do you have business associate agreements with all of your vendors? You better be able to say yes to those who have access to protected health information, and you better have a up-to-date business associate agreement signed. If you have a breach, yep, Terry, 1 second, I'll just finish this and I'll come right back to you. If you have a breach and you have an investigation, one of the first questions that they're going to ask for is what? Do you have a HIPAA compliance manual? Do you have policies and procedures specific to the areas where you just had a violation? If the answer is no, you have bigger problems. Go ahead, Terry. I'm sorry.
No, I apologize for interrupting. I have a question to the panel, and
No, it's okay.
I can't find it anywhere. And so if you can find it for me, you're better than I am.
What's that?
Well, I noticed that a lot of practices are using texting to talk to patients. And some of them are using it on their own personal device and not a company device.
Yeah.
And it's not secure. And I don't know about you guys, but I've had arguments with family members on my phone before, and then I didn't realize that somebody had text me back. And so then instead of sending it to the family member I wanted to complain about, it actually went to the actual family member. Let's just say it wasn't pretty after the fact because you sent it to the wrong person. And so I'm wondering if you, yeah, they're like, did you see what Terry said? Well, yeah. So I'm
Yeah.
wondering if that happens
So let's talk
in
about that.
medical
Yeah.
and what is the rule?
Let's talk about that. So, everything with HIPAA talks about transmission through encrypted devices. Text messaging, for the most part, is not encrypted. Now, I think there is an app. It may be WhatsApp or something like that that may have some encryption capability. But using your personal device as a provider or a healthcare professional to communicate with a patient about their protected health information, their diagnoses, their CPT codes, their outstanding medical bills, etc., not a good idea. You lose your phone, somebody can get access to it. Tell people all the time, don't share financial information via text messages either. Really not a good idea. Hacking a phone is the easiest way for a hacker to gain access to information. So be careful. If you can find an encrypted app, fine, do so. But your communications need to be secure. And again, I am not a fan of texting for a lot of reasons, but I'll stay away from those. But go ahead, Terry.
There's just one more point too, as far as using your phone. We use our phones for everything. I was sitting here last night. I mentioned I'm at my daughter's house, and we have a show on the TV. Dinner's being made, and my husband, my daughter, and her husband, they're all on their phone. I'm the only one not on my phone. I'm like, people, we came out to here for a reason. Get off your phones. But my point is that now people are also using cash apps and Venmo and
Yeah.
Zelle to pay. Well, remember, these apps encourage patients to share and let everybody know. And some of them, I know PayPal doesn't have it, I know Venmo does, where you can't choose the private option where people don't know what you're spending. And so let's say somebody says, I want to pay my copay through Venmo or through a cash app. What'll happen is that anybody that's on their phone or they follow will see that. And the marketers within the app now will send those patients related information as far as a marketing tool. Now, to the panel, is that a HIPAA violation if you're not letting patients know about that people are seeing your information from a payment perspective?
Potentially.
Yeah.
All right. You have any other examples, Terry? Or go ahead, Paul. I'm sorry. Go ahead, please.
What I don't understand is that most, because of the HIPAA security rule, people needed to build patient portals within their EMR in order to communicate back and forth with patients. And these now include payment applications within those patient portals. I have no concept as to why you would text with your doctor with your phone, or why you would send payments with Venmo or Zelle or PayPal or any other type of payment app when all of that is built into a portal. And I have an app for my portal on my phone, and I'm able to do all of that through that patient portal on my phone. It's
Well,
just choose a different app.
and I think I'm with you, Paul, and I think the reason for that is we're old. Like young people, they use all of these things, right? And I think when you're the practice, it's tempting to just say, I just want to make sure I get my money,
Get my money
right?
right.
And so I understand why it happens, and the thing I try to tell people about HIPAA is, while we are all humans making mistakes in this world, certain aspects of our jobs are more important than others. I was once sent out in a fairly large health system. They sent me to a provider meeting, and we worked with like hundreds of providers within this system. And so they would put sticky notes on for like who I was going to see. And this was a doctor, a young doctor, and they had put on the thing that the person's name, and then they said the person was a nurse practitioner. Now, I didn't do that. But I can guarantee you when I walked in there and that person saw that sticky note, it was not a good conversation. And so when I go back to the person at the client site, I'm like, this is a more important part of your job in my world, because I just got like lit up for 15 minutes because this person thought I thought they were a nurse practitioner and not a physician, which of course I think both of these jobs are very respectful. But the same with HIPAA, right? It's like the extra step of care you take when you're handling patient protected health information, whether it's device usage, whether it's checking that extra digit before you fax something, if we're still doing that, or making sure you're sending things to the right insurance company. We've seen examples come through about, same patient name, wrong company. And just in some of the examples that Terry discussed with respect to discussing patient information, just don't do it. I mean, I think I probably speak for all of us on this podcast. Like, I probably look at 10,000 medical records a year, and I can assure you, at least once a quarter, I open one for somebody who everybody on this call would know exactly who it is. But like, the job is just you go in, you look at what you have to look at, and you get out.
I agree. And also remember, and just to my point and to Scott's point, when I talked about somebody at a restaurant or overhearing, I actually have providers sit in their waiting room sometimes and just listen to the conversations that you can hear with the front desk, slider open about other patients and how those patients can hear about other patients. You have to know your surroundings. You have to be cognitive of the fact that patients may know each other. They're coming to a clinic that is in the same, in a location where people try to get close to their homes. So we don't want this discussed over happy hour at, some, event. And all of a sudden, oh yeah, I heard you were over there. How's that going for you? Blue pill. Yeah. Is that working? Yeah. We don't want that discussed. We want things, a little bit, sorry, a little levity there,
Well, and
but we just want to make sure that that's protected.
I mean, that's one of the reasons I don't want to live in a small town. They already know your business to begin with. I don't need like one more
Well,
thing.
I don't live in a small town, and like
To
you
my
said,
world.
we have celebrities in a lot of the different places, but I can't say who they were. I mean, we have to protect that, anonymity. So it's tough though when you hear it. I mean, I'm sitting there waiting to meet with a physician. I'm in their waiting room, and I already know about 5 different patients. Their whole history, because it's being shared at the front desk, and nobody's monitoring that. So just as a lesson to anybody who's watching the podcast or listening to it, you have to look at protection, not just from sending information, but what other people can hear. And that's
It,
what I got on
it
that.
it's always funny that people think that if they stop 5 feet from the desk, suddenly it's the get smart cone of silence where you can't hear anything. You know, I don't think that's the way that works.
No. And the last thing that I want to put out there is, we're talking about privacy, but don't forget security. Your security risk assessments, you have got to be performing these. You have to do an annual security risk assessment. You have to have your risk management program created. If you suffer a catastrophic breach, it's going to be the first thing they're going to ask you for: proof of your SRA. And if you've not done one, it's going to be problematic. All right, let's shift. Man, time has flown by on this episode. And Stephanie, I've never heard you speak so much on one of our episodes. I'm just appalled that you would not allow anybody else opportunity to speak.
No, it's
right.
all right. I'm enjoying it.
Well, stop enjoying it and start suffering along with the rest of us having to
Okay.
use our brain. So, I want to transition over now to talking about specific types of services called RPM, RTM. These are remote patient monitoring, remote therapeutic monitoring, and what are they? How are they different? And why are they such a huge audit target for not only the governmental payers, but for the commercial payers and now the government looking at these fraudulent services? And then we'll kind of spawn off over the last 15 minutes and chat a little bit about how these services are also different from telehealth, Terry and Paul, how they are different from chronic care management. All right, Stephanie, go ahead.
Okay, so first, one of the things I want to say about this, for me personally, I have not had any clients who have dove in and started to do this yet. What I have right now, and actually, it's funny when you brought it up, Sean, because I've had multiple questions about this over the past 3 weeks about. Um, One of the things that I'm finding is I'm starting to dive into everything from the AMA perspective with the CPT codes, looking at the CMS guidelines and how that's laid out, is the fact that this is not just another service that's been implemented to provide practices with more money. And of course, all of the questions that I have are just being driven from the hype right now. You know, some of this stuff is newer. They look at it as that opportunity, as that extra income. But think of it this way, when you are looking to implement any service, whatever it may be, there's always work involved with what is being offered. So when we think about the therapeutic monitoring and the patient monitoring, it comes down to what conditions the patient has basically and what's involved with the information or the data that's being sent back. So in some of these services, it's more of an automatic process where the patients have to be supplied with devices. And, you know, that's another area as well that I haven't personally looked into companies yet, but everywhere you look from a CMS perspective, it keeps talking about making sure they are FDA approved, talking about the ability of the devices. And from a compliance perspective, that scares me a little bit because companies who are starting to create these things are always going to want to push as if they're compliant. So we need to be careful with the devices that are being implemented and used. And, you know, one of the other things that I thought was interesting about this, one of the clients asking the question was stating that they had a competitor. They employ providers who staff different facilities. So they have a competitor who's wanting to go out and this be, you know, kind of their main service. And I'm thinking to myself, how can somebody only monitor a patient, not be connected with the primary care provider? Because I asked over and over again, are they working with the PCP? Are they a third party who's going to do the work like we see with CCM? And the answer is no. So, you know, when we look at the overall picture, it's not just about compliantly gathering the data for these patients. What are you doing with it? It's not just checking boxes to get paid. When you look at reimbursement amounts, maybe it's not even going to be worthwhile to the practice. You know, we have a lot of practices right now who are complaining that they don't have enough staff. There's a lot of turnover. Well, you have to look at it from the whole picture. You're not going to set it up, receive data, and do nothing with it. So you have to look at the provider's involvement personally. Um, think of it this way, we need to have care plans in place. Some of these even require an actual encounter with a provider monthly. So you may be able to incorporate some of that from a telehealth standpoint, but now we're looking at changes from that. You know, does it have to be video? Does it have to be face to face? And then you have, you know, just in general, the monitoring of the information coming in. So who's doing that? Do you pay for a software who's going to alert the provider when the blood pressure readings are off? You know, there's a lot that goes into it, and it's not just an easy money grab like it's being talked about right now.
So, Terry, let me ask you a question if I can. Um, how is it? Let me rephrase. I feel like let me rephrase.
Okay.
Is it fair to say that telehealth services and RPM are not the same thing?
They're
I mean,
not.
can you?
They're not.
Okay. So
Yeah.
what is the primary difference between telehealth and RPM services?
Well, there's something called CTBS, okay, and that's communication technology, and then it's through the systems that we're dealing with technology systems, and they actually aren't tied to the public health emergency or anything like that. They're more telemedicine, if you will. And Stephanie brought up a really good point that everybody seems to miss is that even the CPT book says um, that it has to be an FDA approved device, and we're getting people trying to bill for some of these monitoring things that are on smartphones that may have not been, FDA approved. And or I had a doctor recently say, "Hey, I'm creating this new one. Can I use this code?" I'm like, "No, you have to have this vetted. You have to go through the society of your specialty. They're your lobbying effort. It can't just be that poof, I now have something I can bill for." So that being said, telehealth is different from a public health emergency standpoint, and then post and pre PHE. And I don't think some people are getting that. And actually, I feel bad about that because somebody brought to my attention recently that they were listening to our podcast. And she's like, "You guys had said something about pre PHE, and I only started working in 2021. So I don't even know what pre PHE telehealth is." And I was like, "Oh boy." So when I think of telehealth, I think of it as more of an encounter system where you are substituting that in-person visit by seeing a patient through an audio and video means. And so and that's how it's been worded in all the FAQ sheets, as far as you can bill it if it is audio and video for E&M services, and again, encounter services. Telemedicine is more device related, more has to do with monitoring devices, approved devices, things like that. Now, is there a gray area in between? There is. And it depends on the payer. There's some payers that call Paul had mentioned the portal visits as telehealth, but it's actually on a telemedicine list. It just depends on who you're asking. And there's going to be a post PHE, even with the extensions, there's going to be some post work there where some things have to be identified as telehealth or telemedicine, audio only versus audio and video. As soon as the public health emergency was announced ending, I think a UHC came out and said the 93 modifier for audio only is only going to be for services that are in the Appendix T in CPT. I didn't even know there was an Appendix T. Apparently, I didn't get all the way through my book. So I went and looked in the very, very, very back of the CPT book. I'm like, there it is. But guess what isn't there? Phone calls. So they're anticipating that phone call codes are going to be going away as well, because we know that the panel said they'll be deleted at the end of 2024. So and they're going to have 17 new telehealth codes coming up for 2025. So
Well,
then
Terry,
throwing it over to everyone else. Yeah.
Yeah, Paul, let me ask you to address this, because I thought Christine asked a really great question. And Christine, if I knew you weren't in your statistics class today, you'd be the fifth on the in the squares up here. Nice way to play hooky today. All right, so the question is, what are your thoughts on the stable condition prior to monitoring and continuing to be stable on every RPM monitoring service? Is the service really medically necessary? I'm really interested in your take on this, Paul.
Yeah. I loved this question because this is the fundamental background piece of information for remote patient monitoring, and it's the fundamental philosophical question of all life, which is why. I mean, if you have a patient who is stable, and it was stable at the time that this remote patient monitoring was initiated, and there was no history of this condition being unstable at any time based on treatment parameters, then why are you initiating remote patient monitoring? It's not necessary. Now, the tempting thing is, and I know this because I just ran the bundling edits as I was sitting here, office visits and remote patient monitoring data there's no bundling edit between the two. So you don't even need a 25 modifier to build both of them on the same date. But I tell you what, I don't want to be the guy who is initiating remote patient monitoring for something that doesn't need it and is billing out and getting reimbursed about $50 a pop for going over that data, and then trying to explain why you even initiated that care to a patient who clearly was okay without it.
And, Scott, I actually have a question for you on this one, because one of the other things I've been thinking through and trying to figure out, there's a lot of things we have to look at between the lines with this. And when it comes to that medical necessity, how is this even fitting in? The same people who are asking about remote monitoring want to know about chronic care management. They want to know about principal care management. So how do we justify all of these different services, when they're trying to maximize every small thing that can be billed for?
And I think that's where medical necessity does become key. It's like in some ways we're back where we started, right? Because I get a lot of questions about the documentation aspects of chronic care management, right? Like, is it okay if this person does this task? How do I log this? How do I log that? And we never stop and say, well, what's this patient's need for like this service? How are you defining their benefit? How are you defining, their care plan? Because all of those things are important. The why of the service, as they say.
Yeah.
Yeah, and I think
So
workflow is going to be a big part of that too. Just, like I was saying, if there's staffing issues or if the physician expects to be hands off, that's going to
Well,
be problematic.
Well, and I think sometimes these services come out and the first thought from the business side is let's roll it out like it's a new Slurpee flavor. Like let's get it in everybody's hands. And in some instances, like the provider who's actually rendering the service, the people who are actually logging some of this time are not even in the United States, right? It's like a third party vendor who potentially is not in the country, and that is not certainly not a path I would go down.
can I just say something real quick? Always go with the Slurpee. Do not ever do the Jolly Rancher slushy.
Except no substitutes. And I was actually
Except no substitute.
the way I found out that 7-Eleven apparently bought, I think it's Racetrack, is I went in
Speedway.
there and I saw Speedway. I went in there and I saw a Slurpee machine. I was like, whoa, this is wonderful.
Yep. All right. Before we get too far off track and I start talking about my visit to Wawa, which cost me $42 in pretzels and
Oh,
tasty cakes.
we're going over an hour just on that.
I want to ask this question right here. Who wants to take this one? Pam Vanderbilt put it out there. I think I know the answer, but I want to see what you all say. If an orthopedic surgeon is doing RTM, actually it should be RPM because they're not doing remote therapeutic management. But if they're doing RPM post-operative, is that considered to be part of the global?
Yes, if it's related to what the post-op is. So if it's related to the primary procedure. But they are also doing RTM, Sean. They're doing therapeutic. I hate to call it PT.
Oh, for the pain. I got it. You're right, Pam.
Yeah.
I owe you an apology. I should have thought about the prescribing of the pain management. So
Right.
yes, I was of the mindset. I was thinking of the mindset for like rheumatology, doing therapeutic monitoring, or oncology. I didn't even think about the pain management aspect. So thank you. All right. So I think that covers all of the topics that we had on our agenda for this week. Let me quickly go around the table in the last minute and 10 seconds that we have. Paul Spencer, I'll start with you. Final thoughts.
Well, I don't really have much to add, but again, with remote therapeutic monitoring and remote patient monitoring, the first question you ask is why. And if you don't have a satisfactory answer as to why you're doing it for that patient, then it probably need not be done for that patient.
Terry?
I'm just going to be the commercial message. Go to namis.co and everyone hopefully sign up for our conference next week. We're excited to have you guys see what we have on plan. This week, sorry.
This week.
Wednesday and Thursday, yes.
Stephanie Howard.
Yeah, so just going along with what Paul said with the why, a lot of these questions I'm getting are stemming from the nursing home setting recently. So, When you've already got all that oversight in that facility, why is all of this other stuff necessary? Even if it's covered, we've got to think of the why and medical necessity.
Absolutely. Scott Kraft.
Well, everybody has said the why, and I'll certainly echo that, but I'll also say make sure you're protecting patient data. Take that with the seriousness that it deserves. Take it as in the manner that you would want somebody to be discreet about your own personal or health issues. Extend that courtesy to everybody who comes into your offices.
All right. And my final thought is this week, once again, the heartland of this country, the southeast portion of the United States, we are once again under heavy storm threats, more tornado watches that are looming for us. So I would like for us all to keep the good people throughout our entire country dealing with all kinds of crazy weather systems and things going on in our thoughts and prayers. Terry and I will be back tomorrow with another hashtag Terry Tuesday episode. We have a really neat one scheduled for you tomorrow, and I think you're going to enjoy it. We have some great segments coming up later this week with Legal with Lyles Parker, Ashley Morgan, and Robert Lyles. And until then, as always, to each and every single one of you, thank you so much for tuning in, logging on, and just hanging out with us for a little while. Until we meet again, be good to yourself, but more importantly, y'all be good to each other. Take care.